Hi, I'm Catherine Matthews. Welcome to this educational seminar on some outcomes of sacrospinous ligament fixation, sponsored kindly by Neomedic. I'm going to share with you some applications for sacrospinous fixation, and I'm very excited to share some new data regarding the efficacy and safety of the AnchoSure device. This is a classic run-of-the-mill stage 2 anterior prolapse in which a woman presents with a bothersome vaginal bulge. We see here that she has a small cervix, and in days past, I certainly would have been tempted to offer this patient hysterectomy, uterosacral ligament suspension with anterior and posterior repair. I've come to learn in the last several years, really through my experience with the uphold mesh, that these women seem to do particularly well with uterine preservation and restoration of anterior and posterior midvaginal support, along with apical suspension to the sacrospinous ligament. We found, interestingly, that both the operative time is significantly shorter and there's a trend towards fewer complications if the uterus is left in situ. Obviously, one has to evaluate these women for current and future risk of uterine pathology and ensure that they have a small, not enlarged or abnormal cervix. But if indeed they have a small uterus and small cervix, they may well be excellent candidates for a hysteropexy option. Andre Player, my senior fellow from last year, did a very nice job detailing a video that was presented at AUGS and is published in Iuga, describing the steps and techniques for anterior and apical repair using a sacrospinous fixation technique. When one uses the sacrospinous ligament, you have to have a lot of familiarity about the surrounding anatomy, which neurovascular structures you can run into, and which things you really need to carefully avoid. Here we can see a nice anatomic depiction of the surrounding nerves. The S3 nerve root is actually the closest nerve root to the correct placement of a sacrospinous stitch through the middle portion of the ligament. If we deviate too close to the ischial spine, one can encounter the pudendal neurovascular bundle arising from S2 through 4. If you go all the way through the ligament, one can encounter the sciatic nerve. On the surface of the sacrospinous ligament runs the levator ani nerve. And for a long time, people were concerned about entrapment of this levator ani nerve, and that this potentially could be the explanation for high rates of postoperative pain with sacrospinous fixation. Fortunately, we've evolved in our surgical techniques over the last 10 years and are no longer having to use Brisky Navratil retractors for direct visualization of the sacrospinous ligament. The Mia hook has definitely been replaced in most surgeons' hands by a minimally invasive tool, and here are two examples: the AnchoSure device from Neomedic. Here's an example of the Capio Slim from Boston Scientific, that allow us with haptic feedback to palpate the ligament and then deploy one of these suture capturing or anchor devices into the ligament to suspend the vaginal apex. Here's an example of us at surgery using the AnchoSure device. We have already completed our anterior repair, and we are palpating the sacrospinous ligament on the right side, introducing the protective outer sheath that is about 0.5 centimeter in diameter, and that is covering the anchor which is going to be deployed. Once we're ensuring that we're directly over the middle portion of the ligament, we're going to press down on the plunger and deploy the anchor into the ligament. This is attached, the anchor is attached to a permanent proline suture which can be switched out to a 0 PDS if you're not putting it through the internal cervical stroma. I was really interested in comparing these two different devices, the Capio Slim and the AnchoSure, in terms of postoperative gluteal and thigh pain. And I'm very proud of Andre Player again, who's just had his paper accepted as the editor's choice paper in obstetrics and gynecology in the January edition of 2022. This is a preview of that paper, which will be again out in publication in January. In this primary randomized trial, the objective was to compare the pain in the posterior thigh and gluteal region in the first week after surgery, and we collected data at several different time points, 1 day after surgery, within the first week, and at 6 weeks after surgery, to better define the pain profile of patients undergoing sacrospinous fixation using one of these newer tools. Overall, we assessed 68 women for eligibility and finally randomized 48. There were equal numbers within each group, and this was based on a power calculation of a superiority. We perceived there would be superiority of Ankara over the Capio Slim, as we thought that we would avoid entrapment of the levator ani nerve. What we found overall was that there was no difference between the two devices. Here we have the pain profile outlined for the overall cohort, and we noticed that at 1 day after surgery, about 65% of women reported having more than a 2.5 increase on the numerical rating scale from 0 to 10, with 10 being the worst pain. We see, however, that within the first week, there is a dramatic reduction in pain to about 45%, and by 6 weeks, there was only 1 woman out of 48 who still noted having any pain at all. When we look at some device data, there was no difference in the time to deploying the device. There was about 6 minutes for each of them. And overall, the device evaluation by surgeons found that each performed well in surgeons' hands that were not rated as particularly difficult. We then did a follow-up cohort study where we followed those patients out to 1 year and just had this accepted for publication in FPMRS. This was presented at the Arizona AUGS meeting. What we found from the follow-up cohort study, when we invited women to come back in person at 1 year, overall we found that we had a greater than 90% follow-up rate. In these patients, there was no difference in pain at 1 year, and no patients had any clinically significant pain at the 1 year point. Over the course of 1 year, there were no patients who had to be treated for neuropathic pain, and importantly, no people who had the Ankara device had to have any of the anchors removed. We overall had an exceptionally high success rate. More than 95% of patients met our composite outcome of success of no symptomatic bulge, no retreatment, and no prolapse beyond the hymen. The 2 patients who did have composite failure, this was on the basis of bulge symptoms. We didn't have anyone who required retreatment in the group. This demonstrated to us that not only did the anchor not cause ongoing pain, but it also did not fail. It did not pull out. We didn't have any device failures between the 2 groups. I would be delighted to answer any additional questions that you might have. Please feel free to email me, and I'm very happy to share either of the videos, both the published video and also the technique of application of the Ankara device itself. Thank you so much for your kind attention.
Good morning. I would like to introduce myself briefly first. My name is Andrzej Kuszka. I'm the head of Urogynecology Center Clinic in Germany, in Graz. I would like to share with you my experience with the Remax adjustable tape, which have been used on several thousand patients over 20 years. We know published study have showed that with the help of the Remax adjustable tape, as many as 55 patients, we see 50 patients were cured with adjustment in 2 patients. In 1 case, device was removed for infection. Complication as the traditional retention to the nova urgency. Yes. For another study, very interesting, I would like to share with you. It's this study for 2017 mid-long study, and this were 50 patients 7 years old follow-up, the 90% patient were cured. 6% were improved, and 4% had failed. Considering the mean total score of the quality of life questionnaire, it's increased significantly up to 87.1, 5.9 with improvement of 76.9%. Complications were approximately bacterial cystitis, 6% de novo urgency were 10%, retention 6%, and serometra 2%. I would like to focus in particular on the question of a lifelong adjustable loop replacement for a traditional tape, which indication and which contraindication. We know that the effect of the tape is particularly notable with coughing, laughing, and sneezing. This leads to move in the urethra. The best place for this tape is the proximal third of urethral length. The tape walks in such a way that while coughing, laughing, or sneezing, the tape is moving and is pressing against the tape. This ensures the urethra closed for a very short time. This was confirmed by the study we conducted. If the band is dislocated, for example, placed too high or too close to the bladder neck, the patient isn't cured. On the other hand, if the tape is too far and urethra is hypomobility, then urethra will not close on the tape and the incontinence remains. This should be taken into account when using the Rimex or TVT tape. There are different types of urethra mobility. If we are dealing with hypomobility, we should take this fact into consideration when inserting the tape. In this case, we may have to adjust the band depending on the mobility of urethra. We have different systems which are us to this procedure. However, in my opinion, the most reliable to the best system is the Rimex. I will go into this explicitly in a moment. The point there is remind we can achieve the best result when the tape is positioned in the proximal third of urethral length. If, however, the tape is placed too close to the bladder neck, the incontinence remains. Many specialists have already tried to implant a second tape after already implanting the first tape. However, this can lead to a collision phenomenon, which can result in the failure of the second tape. Similar complications can be observed in patients who have undergone a birch operation, colposuspension, if the bladder neck has been hypercorrected after birch operation, high frozen urethra, then implantation of classic TVT tape is impossible. After inserting the vaginal mesh or laparoscopic mesh with tension under the bladder neck, we deal with frozen urethra. It's still impossible to implant the classic tape. It's important that the shape of the tape stay symmetrical in sagittal and in axial view. With having done pelvic floor sonography, we can easily examine this shape and the distance between urethra and the tape and the place of the tape. The principle is the olive and the mechanism. We have this remix on manipulator, olive, and the band and the tape. It's very easy. The principle is that the olive and the mechanism are increased under the skin in the cavum reti and prepared in the still way for adjustment. Small note, if you follow the process of adjustment, you must not use the manipulator too quickly, so that there is not too much tension and the tape is too close to the urethra. In a post-operatively adjustment, one should work in an environment that is as sterile as possible. It is the procedure, the manipulator will be turned to the right and that leads to the elevator, the move of the mesh. In this video, you can see this method in deal. The fine movements to the right keep the tension low and the shape of the tape is changed by lifting. It's so that it's placed closer to the urethra. This can be noticed by changing the shape of the band. It's the horse shape. As a result, this comes closer to the urethra and pops it up. The less mobile of urethra, the closer the tape should be to urethra. The more mobile the urethra, the farther the tape can be from urethra. The more mobile the urethra, the less tension there is on the tape. When we're talking about the process of loosening, it should be noted that the moment they are turned to the left, an important note is that there can be a certain phenomenon in which the mesh is not automatically moved downwards. When turning the manipulator left, the mesh doesn't move down and the stitches get rolled. In order to lose the tape from the urethra, we can use the Haga pen and put in the urethra and move it down. The disconnector can be removed fairly easy. You walk with the smaller movements so that the disconnector will be rotate 90 degrees and eventually removed. There are different types of urethra mobility which can be determined very well with the help of pelvic floor sonography before and after the surgery. The adjustment to the tape depends on mobility of urethra, and the use of Remex make it easier. If the tape is closer to urethra and the patient can experience the pain or retention, urine retention, and then with the use of pelvic floor sonography, we should determine the placement of the tape to the urethra and the distance of the tape to the urethra. With pelvic floor sonography, having done, we can easily examine this distance and the place. If it is too close, we should lose it. If it's too loose, then we should increase the tension. It's very important here that we remove the system or the disconnector in the right time and in a sterile environment in order to prevent possibly infections. My recommendation here would be 48 hours after the procedure. If you want to measure the residual urine, do not measure in abdominal, but vaginal, as the risk of infection is significantly lower with the second. In these pictures, you can see the system which was removed operatively. Overall, this removal is much easier that of the classic TVT tape. And similarly, it can be said that is the lifelong adjustable system whose replacement is not possible. The indication it's the hypo and hypermobility of urethra, especially with patient. I recommended this hypomobility urethra and the patient with increased body mass index and heavy physical externation. Compared to the this contraindication, look, we should cave on the frozen urethra or short urethra, very short urethra, or patient with overactive bladder or mixed hand incontinence. Thank you very much for your attention. Thank you.